Good afternoon or good evening, depending on where you are. Thank you for joining us for another edition of the ASJ Journal Club. I'm Dr. Maryam Zamani, lead NG editor for ASJ in private practice in Beverly Hills, and I'm joined by my co-moderator, Dr. Deniz Sarhaddi in private practice in St. Louis, and as always, by our amazing phaedra Crest, who runs everything ASJ related. I hope you're all truly as excited as we are because we have a stellar group of experts joining us today to discuss this very interesting paper titled Rupture of Breast Implants Does Not Cause Systemic or Local Immune Changes by senior authors Drs. Galliano, Kim, and Fracol. So without further ado, I'd like to introduce our panelists tonight. And again, remind everyone that you're free. Please utilize the chat box for any questions or comments for our panelists so that we can share them later on in the discussion. So joining us to discuss the paper is Dr. Megan Fracol. She's an assistant professor and assistant program director of plastic surgery at Northwestern, specializing in breast reconstruction and breast and body cosmetic surgery, among many other things. Her research focuses on breast cancer, anti-breast cancer immune responses, from developing a HER2-targeted vaccine to exploring how breast implants may promote local immune surveillance. As our panelists, we have Dr. Mark Clemens, who is a professor of plastic surgery and the Associate Vice President of MD Anderson Cancer Center. Dr. Clemens is an astonishingly prolific researcher with interests in BIA ALCL, as well as robotic-assisted microvascular and prosthetic reconstructive surgery of the breast. He is the breast section editor of ASJ, an author for NCCN guidelines on lymphoma, and an invited expert on breast implant safety for both US FDA and the European Commission. He's also the co-founder of the annual World Consensus Conference on BIA ALCL. Bit of a tongue twister. Who is a past president of the Aesthetic Society. She's in private practice in Nashville and serves as clinical assistant professor at Vanderbilt University. Dr. Haws is also a member of ASBS, Plastic Surgery Research Council, the AMA, and the Southeastern Society of Plastic and Reconstructive Surgery. Dr. Haws uses implants from all the companies available in the US without any financial disclosures. Dr. Haws has co-authored some of the most pivotal studies on implant safety, biospecimen analysis, and systemic symptoms associated with breast implants and management of both symptomatic and asymptomatic patients with breast implants. So let's go ahead and start with a recap of the study by Dr. Megan Fracol.
Awesome. Thank you so much. You can hear me okay, correct? Great. I'll start too by saying I have a 2-year-old and a 2-week-old upstairs at home, so I apologize if you hear some intermittent shouts or a toddler crying in the background. But I'm excited tonight to talk about our study, which is that rupture of breast implants does not cause local or systemic immune changes. There are a couple very important disclosures and funding to mention. Our preliminary work related to this project was funded by Allergan. This specific project was funded by PSF. And then we have an ongoing project related to this funded by ASERF. So breast implants, we know that they're chemically inert. Silicone is chemically inert, and that's why it's been widely used in medicine. For a long time, silicone was also thought to be biologically inert, but that's coming into question recently. Somewhat into question with regards to this elusive concern about breast implant illness. And then initially back in the early 2000s, when there was a ban on silicone implants, there was concern too about could they lead to breast cancer. So that's kind of where our group's interest has evolved around, is breast implants and breast cancer. So back in the early 2000s, a ton of epidemiological studies were done around the world and essentially showed that breast implants, women with cosmetic implants, have significantly lower rates of breast cancer compared to the general population. So opposite of what we expected. And this risk reduction is actually rather significant. So this led us to hypothesize. We know that you get a capsule around the breast implant, and that is essentially the body walling it off, which is why we initially thought they were biologically inert. But that capsule is evidence of local inflammation. And we wondered, does this local inflammation induce a local immunosurveillance that could be protective against breast cancer? So our preliminary studies, we recruited 188 women, healthy women, with and without breast implants, and we tested two things. We tested the peripheral blood for antibody responses to several common breast proteins. These are breast proteins that become overexpressed in breast cancer and that have been shown in other studies to potentially be protective against breast cancer. And what we found is that women with cosmetic implants do have elevated antibody levels to three of these proteins, mammoglobin A, estrogen receptor, and MUC1, and that these antibodies rise shortly after implant placement. The second part of this preliminary study was looking at breast tissue, and we compared breast tissue of implant exposed to implant naive women and found over 2,000 differentially expressed genes in the breast tissue, many of which are implicated in B cell activation and plasma cell activation, which plasma cells are what produce antibodies, as well as T helper 17 cells as well, which we know are involved in the capsule. So that's our preliminary work that led to the study today. And the question today is, what about the implants is causing, if could be causing this local immune change or peripheral antibody level change? Specifically, is it rupture of the breast implants? Traditionally, silicone gel rupture has been thought to be particularly inflammatory. So does silicone gel bleed or rupture confer changes in the local or systemic immune response? So we included it was our prior cohort study. They were all healthy women with cosmetic implants, ages 18 to 80. So we excluded anyone with a history of cancer, anyone with a history of autoimmune disease or immunosuppressed status. And again, we looked at these antibody levels to these common breast proteins. Now, these are all commercially available proteins, which is part of the reasoning for why we chose these. And then we also performed a pilot analysis looking at bulk RNA sequencing of the breast tissue in a subset of patients with rupture and non-ruptured implants. So from our cohort, we had 71 patients initially with breast implants, but we only knew definitively the rupture status on 67 of them. So that left us with 16 ruptured patients versus 51 non-ruptured patients. Comparing the demographics between these two groups, patients who had rupture did have their implants in place for a longer period of time, 28 years versus 7 years, and were more often postmenopausal. Age was almost, seemed different, but did not reach statistical significance. Besides that, there was no difference in other demographic factors, and there was no difference in implant characteristics such as the plane of placement, the surface texture, or the fill. So when we did these analyses, we controlled for implant time since placement and menopausal status using multivariable regression analyses. So comparing antibody levels between the ruptured and non-ruptured patients, we essentially found that there was no statistically significant difference in antibody levels between these two groups for any of the six antibodies we tested, including tetanus as a control. We then asked, we do have a subset of saline patients, so we wanted to make sure that we were not diluting out our results if it was the silicone gel that was the source of inflammation. So we did subset analysis looking at patients with silicone only, comparing ruptured silicone to non-ruptured silicone. We also compared ruptured saline to ruptured silicone, and again, we found no difference between either of those two groups. We also looked at textured versus smooth ruptures and subglandular versus submuscular ruptures. And again, we found no difference in any of the antibody levels between any of these subcohorts. So the next part of our study was we had breast tissue from 5 patients that underwent bulk RNA sequencing, 5 ruptured and 5 non-ruptured. And the heat map on the left, you can see there's really no pattern of differentially expressed genes between the ruptured versus non-ruptured group. For comparison purposes, this was our prior study, the heat map on the right, comparing implant naive to implant exposed patients, and you can see a very obvious pattern of differentially expressed genes between those two groups. But the rupture patients don't seem to be that particularly different. Again, on the right, we have essentially another way of showing this, a volcano plot. There were technically 6 differentially expressed genes between the rupture non-rupture group, but compare that to 2,000 differentially expressed genes in our implant exposed to implant naive patients. So what we're concluding from this is that we think breast implant placement may confer changes to the local immune profile in the breast tissue and may lead to elevated antibody levels to specific breast proteins. Again, this is all correlation. We can't necessarily say causation. But it seems based on this study that it's something about the surface of the implant or the actual physical placement of the implant that confers these changes rather than breast implant rupture or gel bleed itself, which seems to be a relatively inert process that does not contribute to the above findings. In terms of our limitations, this study does have a lot of limitations. We did not look at capsular tissue. Certainly capsular tissue is in closer proximity to rupture, and so that could be different. We were just looking at breast tissue. We also only investigated 6 different antibodies, and they were very specifically chosen because they're commercially available and thought to be important in breast cancer, but there's millions of antibodies you could look at. We chose not to look at antibodies specific to autoimmune disease because that's been pretty extensively looked at already. And then the biggest limitation for RNA sequencing is it's a very small cohort, just 5 patients in each group. So it's possible that we are underpowered to see any true differences. In terms of where we're going next, our next steps are really to figure out if these changes we're seeing in the peripheral blood and locally have any clinical significance. So what we're doing now is we are testing the serum with these antibodies on breast cancer cell lines in vitro to see if they can inhibit tumor growth or tumor development. And then I do think it will be important to continue doing this in larger cohorts with better power in the future as we have more resources and funding available. Thank you.
Wonderful. What a great recap. Thank you for sharing all of that and also sharing some of your background studies that have helped to elucidate your current path and your future directions. I think there's a lot to discuss here, and I'd kind of like to get a sense of what our panelists think of the results of the study and whether it's what they were thinking. So if you don't mind, maybe we'll start with you, Dr. Clemens. Was the lack of upregulation of the immune response in the ruptured implants what you were expecting to see? Did the results surprise you, or is that something that you've been expecting based on your own body of research?
Well, first off, congratulations to Dr. Fracol for a fantastic paper, not only here, but just the beginnings of a body of evidence that I know is going to continue to produce papers in the future. And I think that you're very much a rising voice in breast implant safety. I'm just really looking forward to where your research goes in the future. I would say that the results of this paper are intuitive. It's what we expect to see. For instance, if a patient gets a ruptured implant, they suddenly don't develop autoimmune disease. That's just not seen. That's not in any previous outcome study. And Dr. Fracol has showed it on a marker level, what we would, I think, all plastic surgeons would say we see clinically. So that's very reassuring, but we still needed this study, mainly because of so much different disparate voices that are on social media right now. What it does tell us, and what the data showed previously, is that most ruptures, when they occur in the body, are silent, not noticeable. And because of this, the FDA does recommend surveillance with ultrasound or MRI, and that if a rupture occurs, that the sequela from that is really local. In essence, some of that silicone can be taken up by lymph nodes in regionally, and that's a reason why you should explant a ruptured implant and replace it with a new implant. So that's in line with what the FDA says as well. What this study shows and what our intuition says and what all studies have shown prior is that whether that implant is ruptured or not ruptured, you're not going to get some kind of autoimmune disease based on that. And I just want to compliment also Melinda on the call, as well as Pat McGuire and Carolyn Glicksman paper noting the resolution of BII symptoms if you had an explant. In that, it didn't matter if the implant was ruptured or not ruptured, and it also didn't matter the amount of capsule that you took out, a total capsulectomy or a partial capsulectomy. Some patients got improvement of symptoms, some did not. but that it really seemed to be agnostic to whether the device was ruptured. So I hope we can finally definitively say that a ruptured device doesn't somehow manifest more of these symptoms. Um, I thought it was interesting. I did a little bit of background and I wanted to see what was social media, how were they reacting to this paper? What were they saying? And one question that I saw raised, and I'd love to hear Megan, maybe your thoughts on this, was the idea of a intracapsular rupture versus an extracapsular rupture. That if somehow the silicon were confined inside the capsule, maybe that's why your findings were what they were. I'm playing the devil's advocate here. I think that this is defined. But can you tell us, did you think about extracapsular versus intercapsular? Do you think in your evaluation that that would make any difference?
Yeah, that's a great question. I should have listed that in our limitations as well, because we actually don't have the data on which of these patients were intracapsular versus extracapsular. So that is something that in retrospect, we wish we would have, and we didn't collect that up front. The importance of making sure you have all your data points thought of ahead of time. But that is something that unfortunately we can't really specify if there's a difference there, whether it was extracapsular or intracapsular. And a good question that will maybe be the subject of another study.
Really great questions and really great discussion points, Dr. Clemens. You're absolutely right. This is lending a lot of more, the data that we need to support what we've all been saying for a long time and trying to support both to our patients and to other professionals that sometimes are misled by maybe some case reports or by what they see on social media as well. Among plastic surgeons, one of the things that we do see clinically, though, among with ruptured implants, particularly silicone, is oftentimes worsening of the capsular contracture. So what do you think is the etiology there, where sometimes, of course, we see terrible capsular contractures with perfectly intact implants, but in cases of non-silent ruptures, very commonly the manifestation is a grade 3, a grade 4 capsular contracture. Do we think that there might be something different in those cases? What are your thought processes there?
We did look at in our prior preliminary study, we where we did the bulk RNA sequencing on this 10 and 10 implant naive and implant exposed. We did find that patients with grade 3, 4 CapCon had higher levels of IL-17 or T helper 17 in the breast tissue compared to those that had grade 1, 2 CapCon. I don't know, and probably prone to CapCon. So I don't know if there's something about some interaction between the breast tissue and the capsule. Maybe some women are predisposed to higher IL-17 levels, and that creates some sort of immune response too that contributes to capsular contracture. It's hard to say which one comes first, the chicken or the egg. Do you get capsular contracture and that causes more IL-17 production, or does some patients have a higher level of this sort of immune type response at baseline that causes capsular contracture? But that was one interesting finding was the patients with grade 3, 4 capsular contracture did have higher IL-17 levels in the breast tissue. Interestingly, too, one thing I didn't say here also is time since implant placement. In our prior study, we looked at time since implant placement, and that was the only thing that women had higher antibody levels to MUC1 if they had implants in place for longer than 10 years. So I think, in my opinion, from all of this research, it seems to me that I think it's really something more the surface of the implant. That's the inflammatory stimulus, which we know from textured implants leading to ALCL. And we know from Dr. Clemens' study looking at the micron level of surface texture, how that impacts the immune response at the surface level. We know that I think, what is it, like 4 to 10 microns is the least inflammatory. So in my opinion, I think all of this study really shows that it's something about the surface of the implant more so than the rupture or the gel or any other characteristic of it.
Hmm. And so do we think that the surface is that's more of a mechanical irritant, more of like a micro frictional or frictional component rather than like a true like chemically different composition that's eliciting that response? Do we think that? Maybe Dr. Fracol, Dr. Clemens, if you'd like to pitch in.
May need another journal club for that one.
Okay, well, we will pin that and we will come back to that. Fair enough.
I will say
All
there's
right.
some studies out there suggesting that the silicone acts as like a hapten. I think
Mm,
there's been, gosh, I don't want to misspeak, but I think back in the old days, I feel like they used to add like silicone particles or something to vaccines to act as like a hapten. A hapten
sure.
is something that combines with an antigen to make it more antigenic. So
Hmm.
the way I've like processed this hypothesis in my mind, again, this is just a hypothesis, not proven, but hypothesis in my mind is you put the implant in, the surface gets coated with your own protein, and that interaction between the silicone surface and your own protein causes some proteins to become the silicone acts as a hapten to make them more antigenic. That's kind of how I've
That's a great
organized and
insight.
thought of it in my mind, but I don't know.
Megan, you hinted it in your presentation, the relationship with breast cancer, and I think we definitively shown in multiple outcome studies that breast implants don't increase breast cancer risk. But do you think that there's any effect on potentially lowering recurrence rates or favorable environment? Or should that be a focus of breast implant manufacturers to maybe find an optimal effect on local immune environment?
Well, yeah, there's a Korean study back in, I think, 2022 that compared textured versus smooth tissue expander reconstruction in breast cancer patients. And they found that breast cancer patients that had textured tissue expanders actually had higher recurrence rates at 5 years compared to patients who had smooth expanders. Now that almost seems contradictory to what I'm saying, because what I'm saying seems to say it sounds like what I'm saying is more inflammation means more immunosurveillance. And so you would think texturing means more inflammation means more immunosurveillance, but I don't want to simplify it that much. I think there's something about the immune system so complex and there's so many arms to the immune system. And these arms to the immune system interact with each other and upregulate and downregulate each other. So it's very complex, but I think there could potentially be something about the surface of the implant that, according to that Korean study, that may have an impact too on breast cancer recurrence. In my dream world, I think it'd be really cool to create a breast implant that somehow has been tagged with like almost like a vaccine delivery that could prevent breast cancer, but that's, probably a little out of the scope here.
Fantastic. I'd like to shift our conversation to a little bit more clinical, perhaps, and how we would guide patient care and patient counseling. So I'm going to tag Dr. Haws in for this. And I'd love to know how the findings of this study, or do the findings of this study in any way influence how you will go about counseling your patients who may or may not have ruptured implants.
I think that's a great point, and I think the important thing is, as Mark put out, this kind of reinforces what we've been saying, that yes, the silicone can locally migrate. It's not a 911 emergency if you have a ruptured implant, and you can do your surgery when it works in your schedule. And this reinforces that, right? That this is not changing antibodies, it's not changing the inflammatory antigen component in the surrounding tissues. So it's more data that, as Mark said, we kind of intuitively believed, but didn't have specific hard data that yes, this is correct. And I have to tell you, I'm shocked sometimes at the number of grade 1 capsules that I have that have a massively ruptured implant that's clearly been ruptured for years and years. So I don't think they always cause a grade 3, 4 capsule. I'm not sure that they have anything to do with each other. So it further supports what I'm telling patients.
That's great. That's really good to hear. Now, you've done, a lot of your research has centered around patients with systemic symptoms and breast implants and coming in. So using the data from the study, how would you counsel those patients, and what, what alternative diagnosis or specialist referrals would you think are appropriate before we, kind of go down the list and say, okay, we're attributing the systems to an implant as as a possible etiology?
It's interesting, and I still have these conversations in my office, and not as many because there's enough video of me out there. Most patients come to see me because they know what I believe about this. And I think I
Mhm.
see more breast implant illness systemic symptom questioning patients than true believers, because there are people in my community that take care of the true believers and do exactly what they want. Um, but I do counsel patients that all the data that we have, and again, thanks to Caroline Glicksman and Pat McGuire, I was a contributor to that study, but I didn't do the heavy lifting. But we now have concrete data that says it's not the implant, it's not the capsule per se, it's taking the implant out makes most people feel at least a little bit better. And
Mhm.
that's all, and we don't need to take any capsule out, and that there's nothing special or evil in the capsule that we have thought to be able to test for. And showing this now that just because it's ruptured does not increase your risk of systemic symptoms. And certainly that supports what we saw in our study. It was, if anything, the systemic symptoms cohort, the BII cohort, the only thing that really stood out was there was more salines. But again, was that time-wise, with that a geographic preference, or was it that those were women who were already implant hesitant when they got their initial implants? Because I still see women for primary augs who think maybe they should do saline because they're a little worried about the implants. So this just supports and is just really highly technical data that I can now share this paper with patients who think that I'm making
Mhm.
this stuff up, and see, here's something that doesn't even have my name on it. And it's been done by a really high quality and is showing this data. Megan, I did want to ask you before I forget, has anybody looked at the MUC1 and the mammoglobulin antibodies like in BIALCL patients? Are those different in that tissue, or do you know, Mark?
I don't think anyone's ever looked at that, but yeah, Dr. Clemens would know better.
And not to my knowledge.
Might be interesting to see, do they have the same elevation or less, or does it just one not have anything to do with the other? All
Drop
right,
in.
look at that. I stumped the
Yeah.
experts. I'm so excited.
Cool. Another
That's
route
really
for
great.
study.
I do see that there are some questions popping up in our chat box. I'm going to give Deniz an opportunity to bring some of those forward to our experts. And also, again, remind everyone that this is we want you to be interactive. This is the time we have, the world's preeminent experts on the panel and as well joining us in the call. So if you have any questions, please don't hesitate to put them forth and we will share them. So go ahead, Deniz.
Thank you so much. Just an early question that I would have jumped in with while we were talking about the study itself. Um, they're wondering if you can comment about the small numbers of patients in these groups to do the subgroup analysis, Dr. Fracol.
Yeah, that is again another limitation in terms of numbers for the subgroup analyses. Let me go to that. So for our silicone only patients, give me a moment so I have these numbers correct. Silicone only, we had, let's see here. We had 12 ruptures in the silicone only versus 39 non-ruptures in the silicone only. That was our biggest sub cohort. In terms of silicone versus saline, we had 12 silicone ruptures again versus only 4 ruptured saline. So these are very small cohorts. And then subglandular versus submuscular was 7 and 7. And textured versus smooth was 13 versus 3. So again, major limitation of the study is the small cohort.
And it certainly set the stage for more studies.
Yes.
And then Dr. Holly Wall, she's on the call, and she made a very nice point that Dr. Clemens responded to. I don't want to. Dr. Holly Walsh, she also said that we should consider that these ruptured implants in the study are earlier generation, the ones that used to leak, and they still didn't create a negative immunologic response.
It's a good point. Yeah, average time of the implant placement was 28 years. So yes, these
Wow.
would be mostly placed in the late 90s, early 2000s, late 90s for a lot of them.
And that's all we have in the chat. Do any of our other experts on the call want to chime in or add anything?
Well, just what Holly was bringing up was that we always have to, when we're talking about breast implants and the effects of rupture and what happens when they do, we have to really take into account what generation we're dealing with. For instance, the FDA requires that we do these checklists with our patients when placing of a breast implant. One of the criticisms of those checklists is that they require utilizing core data. Core data usually is done prior to implant approval. And so for Allergan and Mentor, it represents decades old data with devices that were low cohesive, essentially liquid silicone on the inside. Increasingly, we just don't utilize these devices anymore, and yet we're quoting complication rates based on devices that we're not placing. If you look at Allergan, their top sellers are their higher cohesive implants. The responsive are used much less. If you look at Mentor, their boosts are going to be their highest selling implants, followed by the Extra, and their classic versions are their least sold at this time period. So the whole market is going in the direction of higher cohesivity. We know that that translates that a higher cohesive implant has less gel bleed, and if it ruptures, it shouldn't really go anywhere. In a fantastic paper from last year, Mikkel Hurley, a researcher from Denmark, showed that that presence of low cohesive silicone directly was responsible for capsular contracture, and that a higher cohesive implant has lower capsular contracture. We see that in outcomes studies, that some of the core data from recently published silicone implant trials showing remarkably low capsular contracture rates, but they're using our highest cohesive devices to do that. And so I just really liked Holly's point, is that let's make sure that we always compare apples to apples and don't try to compare a device that was used 30 years ago and has fallen out of favor with a current device to try and make sense of it. It just doesn't work. Let me sum up all of that, is to say that I think that implants are more safe than they've ever been. Our outcomes are definitely showing that. And I think that this is one more study that should be reassuring to patients and surgeons.
Absolutely. I think that the body of evidence is just really growing, and I hope that it makes surgeons feel a lot more comfortable in the choices that they're making with regards to, treatment of cosmetic and reconstructive patients with breast implants, and also the way we're able to educate our patients, but also our colleagues that are sometimes, our non-plastic surgeon colleagues that are still sometimes misled by some of the false information out there and such. I'd like to, knowing that we have, our other leading experts, doctors McQuire and Glicksman on the line. I'd like to see if they have anything they'd like to add to this discussion. I know that they speak on this all the time, and we do tap them for quite a lot on the ASJ Journal Club, but I would like to open the floor to them if they'd like to pipe in as well, or if they chime in with any of their pearls and insights.
Well, I just think, Megan, the studies that you guys are doing are amazing. And I think what's been lacking in implant information has been science. And that's why we did the study that we did, and felt like we had to give answers for the patients, because we were seeing patients with all these symptoms they were attributing to their implants, and they were getting better. So all of this, association versus causation stuff, now we can go in with data and talk to our patients. And this just shows in our study, there was actually more ruptured implants in the non-BII cohort than in the BII cohort, more textured implants in the non-BI because it was we started our study right at the time when BioCell was taken off the market. So it's not the surface of the implant, it's not the fill of the implant, it's not the textured or non-textured. It's the presence of an implant in these patients, and it's does not matter what type of implant that it is. So that's I think this just goes along with what we found as well. And I think a lot of these numbers will get better as the implants keep getting better. So I just really applaud what Megan, with everything you guys have been doing, just adding more to the body of actual science to this. The problem is we're still not making a lot of headway with the patients. You know, they're still all going to these groups. We have surgeons still talking about how these patients are going to die if they don't have their implants and capsules out within a few months. I had a patient come in a couple weeks ago, sent by her naturopath with to have her implants out because she had these nodules all over her body. And he put her on ivermectin and said, you need to get your implants out because these are silicone. So I took a look at one of these nodules. I said, I'm going to remove this. And it was metastatic melanoma. And her BII group and this naturopath had been telling this woman, this is silicone. And even the group, when somebody told her it might be cancer, they said, well, it doesn't matter because unless you get your implants out, you won't be able to fight the cancer because of the effect on your immune system. And what this just showed is there's no effect on peripheral immune system, ruptured, non-ruptured implants. So we're very grateful to have more science so to hopefully prevent these kind of tragedies.
Absolutely. Okay. All right. And I think as a final closure, one of the things that I think is important, and again, to bring some of our other breast surgeon experts on the call to hear their opinion. Dr. Hollywell was kind enough to bring us that topic to attention. I'm going to invite both Dr. Hollywell and Dr. Simeon Wall to give us their insight. At the aesthetic meeting just previously, I attended one of their courses where they really wanted to emphasize that their approach has been migrating away from doing a lot of capsulectomies. And I think some of the data that we've been discussing right now is pretty instrumental towards that. So I wanted to give them an opportunity to speak on their surgical approaches and how this maybe influences that and informs that as well.
Oh, thanks for inviting me to talk, and Simeon is here too. I think the way I describe this to patients is that capsules are your body's reaction to save you. It's a protective mechanism, just like fingernails and eyelashes, and unless it's actually pathologic, we need to keep it. It's doing exactly what it's supposed to do, which the study shows. So this only reinforces exactly how I feel. What about you, Simi?
I just want to echo, I'm just so appreciative that you guys are doing these studies, and all of you, everybody who's spoken today, you guys are all a big part of this. And I do think we're starting to turn the tide. I think most of our patients are reasonable, at least the ones we see. Like Mindy said earlier, they kind of self-select a little bit, so we don't get the ultimate true believers. But I think the people that are just kind of inundated with TikTok and all the social media, they just want some truth. And these studies are so valuable. Thank you guys. I thought this was really, really great. And I love that I've got a few things to think about what it means. And I know you've got some follow-up studies, but it was very intriguing. I appreciate you guys.
Thank you, both of you. And so with that, I'd like to bring this to a close. But before finishing, I'd like to ask Dr. Haws if she has any final remarks for us, any final pearls.
No, I think this is great. And I think the biggest thing, and Pat and Caroline and I have talked about this oftentimes, is with these systemic symptom patients, we really still have to be doctors because, like Pat, doing this biopsy on this poor woman who she didn't tell you had already seen a general surgeon, PA, and somebody else, and nobody had done the right thing. We are sometimes the last stopgap to make sure these people get appropriate treatment. And, you know, systemic symptoms from breast implants is a diagnosis of exclusion. So you just still got to be a good doctor and make sure they're getting a full workup. I've had 2 terminal cancer diagnoses that came to me with BII.
Wow. That's really great food for thought for all of us to consider, and just remember to, really look at our patients holistically and not, and always, leave BII or systemic systems as a last consideration, but really make sure that we are there, like you said, to be a stopgap for our patients. I think that this has been such a wonderful discussion. I'd like to thank everyone who's attended. We've had such a great attendance on this call, and it's entirely to the caliber of this great study and the excellent panel that's joined us today. So I'd like to thank all of you today, and thank all of our attendees tonight as well. And I hope that this has been, a reinforcing, not necessarily an eye-opening, but a reinforcing journal club that's empowering you to have the discussions that you need to have with your patients and any of our other healthcare colleagues, so that we can deliver the right care to our patients. All right. With that, thank you so much. Have a lovely afternoon, evening, and please don't remember to just stay tuned for our follow-up ASJ journal clubs that will be coming up. Next one will be led and moderated by my colleague, Dr. Sarhaddi.
Thank you all so much.
Thank
Appreciate
you.
it.
Thank
It
you.
was a
Good
pleasure.
night.
Thanks.